Hi, this is Jim Eubanks, and I'll be discussing cervical fusion today. I'd also like to thank Brandon Barnt and Sarah Smith for their contributions. The learning objectives for us today are to review the anatomy relevant to cervical fusion, to understand the indications for the procedure, and to familiarize ourselves with some of the studies looking at efficacy, to understand the basics of how the procedure is performed, and to address frequently asked patient questions, including those about potential risks and complications. So this is largely a reference slide for your benefit, where you can review some of the anatomical landmarks on the cervical vertebrae that would be relevant to a cervical fusion procedure. While anterior cervical fusions are by far the most commonly employed, posterior cervical fusions can be used for specific reasons. So there are three categories of instability that we'll review now. Regarding cervical fusion, the treatment target is most often this spinal instability. Unfortunately, spinal instability is not well defined, partially due to the difficulty measuring this. A simple way for us to approach this spinal instability definition would be to subdivide it into three categories: overt, anticipated, and covert. Overt instability would indicate excessive motion that is readily seen in radiographic studies and results in pain, deformity, and/or neurological deficit. Acute overt instability includes etiologies such as fractures, dislocations, tumors, and infectious processes. Causes of chronic overt instability include spondylolisthesis with movement on flexion extension films, or any spinal deformity such as kyphosis, scoliosis, etc. that progresses over time. Overt instability will generally require external bracing or internal fusion stabilization. Anticipated instability can be defined as excess motion produced by a decompressive surgical procedure, such as resection of a lesion. Covert instability is excess motion that cannot be clearly demonstrated, but is presumed to exist based on radiographs and clinical findings. So fixed spondylolisthesis without movement on flexion extension films in the clinical setting of increasing back pain or worsening radicular symptoms would be an example. Degenerative spinal diseases are controversially included in this category. The concept of microinstability is sometimes used to justify spinal fusion in a wide range of conditions, including recurrent disc herniation, disc degeneration with discogenic pain, spinal stenosis, etc. Considering the indications for cervical fusion, which is another source of great controversy, and overall spine surgeons have become more conservative over the past several years, for good reason. According to NASS, the North American Spine Society, appropriate use criteria for cervical fusion: degenerative cervical spine disease that has failed conservative management and that has been treated with discectomy is the prior indication for subsequent fusion. Usually the discectomy is part of the same procedure, of course, that the fusion is associated with. Cervical spine pathology resulting in radiculopathy, axial pain, and/or myelopathy are clear indications. Continuing, when we consider these indications, central stenosis carries more weight than foraminal stenosis, which carries more weight, of course, than a lack of stenosis. If there is radiculopathy and/or myelopathy, such as a myeloradiculopathy, Both single-level and multi-level fusions are often appropriate. In the rare case of refractory axial neck pain that is unresponsive to appropriate trials of conservative care, usually only single-level fusion, if any fusion at all, would be appropriate. Cervical fusion is also appropriate for certain cases of scoliosis, especially those with a high likelihood of progression or segmental degeneration, spondylolisthesis that is symptomatic and unresponsive to conservative care, and spinal fractures requiring stabilization. Contraindications, absolute contraindications include diffuse neoplastic disease lacking adjacent normal segments. In other words, you could not actually place the fusion instrumentation. Severe osteoporosis precluding successful instrumentation or fusion, and adjacent infections. Relative contraindications include smoking, malnutrition, and medical and psychosocial comorbidities. The approaches to a cervical fusion include the most common, which is anterior approach. This has been the case for over 50 years. Total discectomy alone results in spontaneous fusion in 70 to 80% of cases, interestingly. Discectomy with an interbody fusion using standalone iliac crest autograft is considered to be the gold standard. The posterior cervical fusion is performed usually for instability or fractures. It may be employed in conjunction with anterior cervical fusion when multiple levels are involved. One prospective study with 81 patients that looked at anterior cervical fusions with 2-year follow-up demonstrated significantly worse radiographic and clinical results with standalone autograft compared to autograft supported by anterior plating or artificial fusion substrate with anterior plating and cage implant. So even though most discectomies will spontaneously fuse, instrumentation allows for superior clinical outcomes. The anterior cervical fusion autograft technique includes approaching the target segment through laparoscopic method, performing the standard cervical microdiscectomy in most cases. This would involve inserting a vertebral distractor between the adjacent vertebrae and removing the disc material and the posterior longitudinal ligament. The end plates are prepared for interbody fusion, and the autologous trichordal bone graft from the patient's iliac crest is harvested. The graft is inserted into the empty disc space. Optional anterior plating is secured with screws, which we can see in the left on the radiograph, and a lateral fluoroscopy to confirm proper placement of the grafts and implants is performed. The risks and complications for cervical fusion include failure of the fusion or non-union, autologous bone donor site morbidity at that iliac crest where the bone is harvested, a dural leak. Remember that we're using sharp metal instruments around a vulnerable water balloon, essentially. Infection, dysphagia, which generally subsides within several weeks for most patients. Odonophagia, and feeling tightness between the scapula. Considering some of the frequently asked questions that patients may have. One may be, what can be done to improve fusion rates? First and foremost, so this is an important question, and smoking has been found to significantly inhibit bony fusion. So it would be important to stop smoking, and in fact, for elective spine procedures, Many surgeons will tell patients that they actually have to stop smoking entirely before they'll do the procedure now. The outcomes are that significantly different. Secondly, avoiding NSAIDs, which can interfere with the normal rate of fusion. Occasionally, insurance companies will approve a bone growth stimulator, which does also enhance fusion rates. Patients may ask about their cervical collar, and in particular, if they can sleep in this. And patients do not need to. It's not required, and we can remind them that in the case of instrumentation fusion, the instrumentation is incredibly durable and usually not at risk once placed. After cervical fusion, patients will ask about sleeping positions in many cases. And it's okay for patients to lie in any sleeping position that allows them to sleep best, and that would be the message to emphasize. Some will prefer modifications that can include wrapping a small towel up in a roll and putting it under the small of the neck when they are sleeping supine. And some will prefer, nonetheless, to lie on their side with supporting neck pillows. Another question is, how long will it take to recover from a cervical fusion? The length of recovery, of course, depends on many different patient factors, generally their overall health. But most people are able to return to work a few weeks to at least a couple of months. It is perfectly safe for patients who are not enduring heavy loads and lifting as part of their essential daily work to return as soon as 2 weeks after the procedure. Risks of the surgery we have discussed, but patients will still ask this question, so it's important to remind them of the infection risk, the blood clotting risk that comes with any kind of orthopedic procedure, the reactions to medications and anesthesia that may be required. Spinal surgery has additional risks to the delicate nature of the spinal cord and the nerves coming out. So another, of course, is the headache, which tends to improve when lying down as the hallmark of a CSF leak. The incidence there is only 2 to 5%, and these usually will resolve on their own. Hopefully this lecture has allowed you to review some of the anatomy, to understand the indications for cervical fusion and some of the controversies, and to familiarize yourself with some of the literature looking at efficacy. Hopefully you can understand the basics of the way the procedure is performed and address frequently asked questions that patients may have, particularly those around risks and complications.